Sure. Uh, Regarding the fungal infections in ICU, like when do we suspect that the fungal infections are forthcoming, or the fungal infections are coming, or the fungal infections are there? How do we suspect the impending doom of the fungal infections in ICU? In COVID, we all have learned regarding the black fungus. I think it came in all over national news regarding black fungus. So, in ICU or in any ward or in any OP patients, supposedly the patient has risk factors. A patient is diabetic, a patient is hypertensive, a patient is immunocompromised. By immunocompromised, what you mean? The patient has any immunological diseases, systemic lupus erythematosus or Sjogren's syndrome, or any immunocompromised disease. Or if the patient is any post-transplant patient. By post-transplant means if the patient has undergone a renal transplant, a hepatic transplant, for which the patient is on steroids. Even those patients who are chronic COPD patients who are on long-term steroids, even they are prone for fungal infections. Okay. In ICU, what are the risk factors? A central venous catheter, which has been there for the last more than 7 days. Arterial line, which has been there for the last more than 7 days. The most important risk factor for fungal infections in ICU is the length of ICU stay, isolated length of ICU stay. Okay, any patient with length of ICU stay of more than 7 days is at a very high risk for fungal infections in ICU. Okay, so regarding these are the risk factors that the patients will have, and we need to understand that okay, if these risk factors are present, we have to think towards fungal infection. There are various scores like Candida score is there, one multifocal colonization score is there. So various scores are there which we can always calculate and see whether the patient is at high risk for fungal infections in ICU. For Candida score, generally we see points like sepsis, whether there is colonization, whether there is TPN is there, or whether there is sepsis is there. Any patient with sepsis has got a score of more than 2. Okay, so isolated presence of sepsis will predispose the patient towards fungal infection. Any Candida score of more than 2.5 is considered to be a serious threat to the patient for fungal infection. So isolated presence of sepsis will give that score of more than 2. So that will lead, that gives a false positive impression that any patient with sepsis has got a good Candida score and he should be started on antifungal therapy, which should not be. Okay, so we need to see multiple other factors, the clinical conditions, whether the patient actually need the antifungal therapy or not. Okay, so these are the risk factors. Now, how do we diagnose? The most common method that we use is a blood culture. Do anyone have any idea about other methods of diagnosing fungal infections in ICU? There are two other methods. One is called 1,3-beta-D glucanase. Okay, in which we send the blood samples to see 1,3-beta-D glucanase, in which the sensitivity is very low. The sensitivity hovers something between 25% to 80-88%. Okay, the specificity is something around 80 to 95%. So with a low sensitivity, it's difficult to diagnose fungal infections with 1,3-beta-D glucanase. 1,3-beta-D glucanase has got other disadvantages apart of low sensitivity. What is the other method that we can diagnose fungal infections in ICU apart of 1,3-beta-D glucanase? Huh? Pardon? KOH mount. It is very preliminary method. That is like first method. It's difficult. So generally we used to see the blood cultures or 1,3-beta-D glucanase, and a couple of more tests, PCR based tests are there, but they are very costly. Okay, and the sensitivity is still on the lower end, mind it. Okay, so any patient that we see with a fungal infection, how do we approach the treatment? Supposedly a patient is there who has got a fungal infection, a suspected fungal infection or evident fungal infection, and the patient is hemodynamically unstable or the patient is having neutropenia. These two factors are very, very, very important. Hemodynamically unstable and neutropenic patient. If these two factors are present, you don't think of fluconazole. Okay, you have to think towards a higher antifungal such as a amphotericin B or a echinocandins or liposomal amphotericin B. But if the patient is not hemodynamically unstable and if the patient is not neutropenic, then you should always consider for fluconazole therapy. So we have two options, whether we should go for a fluconazole therapy or we should go for a higher antifungal such as echinocandin or a amphotericin B. By by echinocandin, caspofungin is there, micafungin is there, liposomal amphotericin B is always there, and uh, this fluconazole and itraconazole and other therapies are there. So these are initial therapies that we most commonly use, the fluconazole therapy. Now, if the patient is hemodynamically unstable and neutropenic, we straight away go for a higher therapy like as echinocandins or liposomal amphotericin B. Now, if the patient is non-neutropenic and non-hemodynamically unstable, we'll go for fluconazole therapy. How long do we give the therapy? The duration of the therapy stands 14 days after the negative culture report. So, supposedly, today we are getting a positive culture report. After every 5 to 7 days, we need to resend the cultures. Okay, so that we come to know that when supposedly the date is 10th the patient has come negative. So till 24th we need to give the therapy. And mind it, antifungal therapy is very costly. Okay, and one therapy of liposomal amphotericin B costs something between 5 to 6 lakhs for the patients. Okay, so they are very costly. So we need to judiciously plan the therapy, and because the cost of the therapy is very high. Okay, what are the options that we have if the patient is growing candida? Candida may be albicans or the non-albican species. We can always go for fluconazole, but in certain species of Candida, fluconazole is not useful at all, such as the Candida krusei, in which if the growth culture shows Candida krusei, you should never use fluconazole because that is not going to work by any means. You should straight away go for the echinocandins or amphotericin B. If the patient is growing fusarium, like mucor, again there is no role of fluconazole. Okay, you have to move towards liposomal amphotericin B or the echinocandins. If the patient is growing invasive aspergillosis, there is no role of fluconazole again. You have to go towards voriconazole, which is a drug of choice for invasive aspergillosis, or you should move towards something like echinocandins or liposomal amphotericin B. If you say one drug which acts on all is the amphotericin B. Okay, amphotericin B, there are various formulations of amphotericin B. It can be plain amphotericin B deoxycholate, it can be amphotericin B colloidal dispersion, it can be liposomal amphotericin B, and other forms are also present in the market. Amphotericin B deoxycholate is highly nephrotoxic, just like fluconazole. Okay, and when we use the echinocandins such as caspofungin, they are hepatotoxic. So we should try to keep in mind these two factors, that okay, whenever we are using fluconazole therapy, we should go for regular renal parameters monitoring. When we are using caspofungin, we should go for regular hepatic function monitoring. So these are the therapies that you can use for various fungal infections, and the duration of therapy is very important, which is 14 days after the negative blood culture. So the next time whenever you get a culture report positive for for any fungus, after every 5 to 7 days you should repeat the culture. Then only you will be understanding, okay, how long are we actually going to give. The moment it comes negative, you have to add 14 days to it and then continue the therapy. Okay, so that's it. Thank you.